Chapter 20. Oral cancer. More than 90% of malignant neoplasms in the mouth are squamous cell carcinomas arising from mucosal epithelium. Most of the remainder arise in minor salivary glands, ch. 23, and a few are metastases. The term oral cancer is therefore used loosely to mean oral squamous carcinoma. Carcinomas of tonsil, pharynx and lip are considered in the next chapter. Epidemiology. Oral carcinoma accounts for only approximately 2% of all malignant tumors in such countries as the United Kingdom and the United States. In most countries where reliable data are available, the incidence of cancer of the mouth, although variable, is low. India, Pakistan, Bangladesh and Sri Lanka are, however, exceptional, and cancer of the mouth accounts for approximately 40% or more of all cancer there. Although the incidence varies widely in different parts of this subcontinent, relatively high rates are found in parts of China, Southeast Asia, France, Brazil and Eastern Europe. This variation is largely due to tobacco and other habits, and incidence is rising in these areas. People who neither drink alcohol nor smoke, such as Mormons and Seventh-day Adventists, have very low rates of oral carcinoma. Approximately 4,000 cases of intraoral carcinoma are registered each year in the UK. This equates to an incidence of 4.8 and 7.3 cases per 100,000 population for females and males respectively. For the last 50 years, the incidence of oral cancer has been falling in many developed countries such as the United States and in Europe. In the United Kingdom, unusually, oral carcinoma incidence has been slowly rising, Fig. 20.1 and 20.2. Claims that oral carcinoma is increasing dramatically are accounted for by inclusion of oropharyngeal and tonsil carcinomas in the total. These cancers are not oral, present and behave differently and are discussed in the next chapter. Cancer registry data often compile lip, oral and oropharynx together, and together these account for more than 7,300 cases each year in the UK. Fig. 20.1 Incidence of oral, red, oropharyngeal, blue, and lip carcinoma, green. For the UK until 2013, to show the dramatic rise in oropharyngeal carcinoma, ch. 21, relative to oral and lip carcinoma at that time. Data from National Cancer Intelligence Network, England, Information Services Division, Scotland, Welsh Cancer Intelligence Surveillance Unit and Northern Ireland Cancer Registry. Web URL 20.1 International Epidemiology http URL. Web URL 20.2 US Epidemiology. http URL. India Epidemiology PMID 23,410,017 Web URL 20.3 UK Incidence, Mortality, http URL. And enter cancer registration in search bar. UK Epidemiology PMID 30,412,558 Age and sex incidence. Oral cancer is an age-related disease, and 95% of patients are older than 40 years. With median age at diagnosis of just older than 60 years. There is a sharp and virtually linear rise in mouth cancer with age, as with carcinoma in many other sites, and oral cancer will become more common with an aging population. Though incidence in the UK is rising fastest in the 50 to 59 years age group, Fig. 20.2. The increased number in the oldest age groups is explained by their increasing total population. Cancer of the mouth is considerably more common in men than women in most countries, but this is tobacco and alcohol related. In the UK the male-female ratio has sunk to 1:5 to 1, and figures for South East England show little difference in incidence between the sexes. The change is the result of the progressive decline in oral cancer in men, but a low rate in women. However, there is a worrying but relatively small increase in rates in young people, particularly women. Fig. 20.2 Age standardized incidence rates for oral carcinoma, including lip, in different age groups with lines marked to show age groups in years. There is an increase overall, but the youngest and oldest age groups are relatively stable, and people aged 50 to 69 years show the greatest increase. Data from the UK National Cancer Registration Service Cancer Analysis System at 2021. BO by 20.1 CANCEROF the MO UTH. Key YFEA TER ES accounts for approximately 2% of all cancers in the UK, one of the most common cancers in the Indian subcontinent, males more frequently affected. Most patients are older than 40 years and incidence rises with age. Posterolateral tongue is the most common site within the mouth. Some arise in pre-existing white or red lesions. Tobacco and alcohol are the main causes, in the Indian subcontinent and Southeast Asia. Betel quid is the main cause. Oral cancer carries a relatively high mortality BO by 20.2 PO SSIBLEAETOLOG ECOLF. ACTORSFORORALCANCER. Major factors: tobacco smoking, smokeless tobacco, betel quid habit and oral. Submucous fibrosis, alcohol, sunlight, lip only. Ch. 21. Low risk factors: diet, candidosis, human papillomavirus *operator, lichen planus. Rare, but significant, dyskeratosis congenita, Fanconi's anemia. Syphilis, historic. Speculative factors: radiation, immunodeficiency *operator. Human papillomavirus infection seems to carry a low risk in the oral cavity but is a high-risk infection in the oropharynx, ch. 21, and nose. Key epidemiological features of cancer of the mouth are summarized in box 20.1. Health inequality and oral cancer PMID, 21,490,236. Etiology defining the contributions of different causative factors is difficult. The disease is complex and multifactorial, and patients must be exposed to causative factors for a prolonged period to develop cancer. Risk factors for oral squamous cell carcinoma are summarized in box 20.2. Worldwide, tobacco is by far the most important cause. Tobacco use, the earliest recorded tobacco-related death, although unsuspected at the time, was in 1621 when Thomas Heriot, who introduced clay pipe smoking to England, died of lip cancer. It has taken many years to finally establish beyond doubt that tobacco is the major etiological factor for oral carcinoma. Fig. 20.3 Tobacco for sale in Brazil. Thick ropes of tobacco leaves for smoking and chewing. Such tobacco has been hardly processed, and carcinogenicity varies with the origin of the tobacco and the way the leaf is cured and processed. Courtesy Drive C. Gomez. Tobacco may be smoked or used in various smokeless tobacco habits, and effects of each are different. Methods of processing tobacco before use also vary widely and affect its carcinogenicity. Fig. 20.3. Nearly 6 trillion cigarettes are smoked each year worldwide, and consumption continues to rise, with the highest intakes in Russia, China, Central Asia, Southern and Eastern Europe. Asia, Southern and Eastern Europe. In much of the world, smokeless tobacco predominates. On a slightly more optimistic note, the proportion of the world population that smoke has been declining for 40 years, but the reduction is more than compensated for by population growth. Though use in the UK has reduced, smoking still kills almost 80,000 people each year and many more have smoking-related morbidity. Tobacco use should always be included in a medical history. And the best way to express cumulative tobacco exposure is in pack years, units of 1 pack, of 20 cigarettes or equivalent, smoked every day for 1 year. Multiply packs per day by years smoked. Web URL 20.4 pack year calculator. HTTP URL. Cigarette smoking. Smoking is the major etiological factor, particularly in association with alcohol, and its importance is that it is preventable. Large epidemiological studies of over 1 million individuals in the United States reveal that smokers' risk of cancer is proportional to the amount smoked and years spent smoking. Smokers overall have 30 times the risk of oral cancer versus people who never smoked. It is estimated that 80% to 90% of all oral cancers can be attributed to smoking. Smoking continues to be more common in men than women, but the gap is not that large, about 3%. Until recently, 1 in 5 adults in the UK smoked, and the level had been in only a slow decline. However, vaping and the disproportionate effects of COVID-19 infection on smokers have promoted smoking cessation, particularly in younger age groups, and in 2022 only 12% of the UK population smoke. Fig. 20.4. The average smoker smokes 31 cigarettes a week. The higher risk habit of hand-rolled cigarettes has doubled in incidence and carries a higher risk of lip than intraoral carcinoma. Over 2 million smokers have switched to electronic cigarettes in just a few years with potential risk reduction. Fig. 20.4 Smoking prevalence in the UK by age. The line for each decade age cohort is labelled with age in years. Note the recent marked reductions in smoking in the 18 to 34-year-old age group. Data from UK Office for National Statistics Annual Population Survey. Smoking is also in decline in the United States, Australia and Northern Europe. Improvement in cancer incidence lags behind changes in smoking habits, and it will take decades for these changes to take effect. In the meantime, consumption is increasing in the developing world. Unlike pipe smoking or smokeless tobacco use, there are no specific oral lesions related to cigarette smoking, although cigarette smokers develop patchy mucosal pigmentation and light keratosis if they smoke heavily. Marijuana smoking is widespread, and the smoke contains many of the carcinogens and co-carcinogens as tobacco smoke. It is suspected that it may be a more potent carcinogen than tobacco alone, but this has proved difficult to separate from the effects of alcohol and tobacco smoking. Tobacco-induced cancers and deaths are preventable. Smoking cessation is discussed in Chapter 19 with management of potentially malignant disorders, but is equally important in managing patients who already have a carcinoma. It is unclear how much the risk reduces after quitting smoking. There are substantial reductions in risk of 50% after stopping smoking for 5 years. But data on lung cancer suggest that the risk will never drop back to that of someone who has never smoked. Nevertheless, stopping smoking significantly reduces risk, reduces comorbidity that can impact on treatment outcome, and reduces the risk of a second primary cancer. The risk of pipe. Smoking a Western-type pipe is statistically equal or slightly less than cigarette smoking due to less deep inhalation. The lip is considered at high risk. Other types of pipe used with different tobacco products in developing countries carry a higher risk. Heavy pipe smokers may also develop stomatitis nicotina of the palate, ch. 18, a white patch with no malignant potential. Risks of pipe and cigar smoking PMID, 20,162,568 water pipe smoking until recently, smoking water pipe, shisha. Hookah or narghileh was a habit practiced largely by older people in Asia and the Middle East and was in decline. However, shisha smoking has become popular with adolescents and young adults in the UK and other westernized countries. Popularity is driven by the social context in which the pipe is smoked, the use of flavored tobacco, moasal, and the mistaken belief that bubbling the smoke through water reduces its toxicity. Most carcinogens are aromatic hydrocarbons or other water-insoluble compounds that are not absorbed by the water, and the cooled smoke is inhaled more deeply to exert greater effects. When this is considered with the long duration for which water pipes are smoked, one pipe session using a tobacco mixture could be equivalent to smoking between 50 and 60 cigarettes. Unfortunately, like vaping, regulation lags years behind widespread adoption. In both the UK and US, it is estimated that around 11% of the population have tried the habit. Only 2% to 3% are regular users. Use often starts in childhood and is much more frequent in young people from minority ethnic backgrounds. The risks of water pipe use vary with the combustion method and the smoked material, traditionally charcoal and tobacco. Inhaling charcoal smoke carries an acute risk of carbon monoxide poisoning. Pure tobacco was used traditionally, but most young users smoke flavored tobacco mixtures, which are about a third tobacco with honey or sugar and flavorings. These additional components also produce carcinogens on combustion or electrical heating, so that tobacco-free smoking mixtures cannot be considered risk-free. Charcoal combustion produces aromatic hydrocarbons as well as carbon monoxide, and electronic shisha, a vaping-like alternative, avoids this but often contains nicotine. Based on limited data, hookah is highly damaging in terms of lung inflammation and cardiovascular changes, as well as being highly addictive. All types of shisha may be more damaging than cigarettes, though research is sparse and the time required for cancer to develop is long. Any habit that involves inhaling combustion products must be considered carcinogenic. UK water pipe epidemiology PMID, 24,550,100. Tobacco habits and their risks are shown in Table 20.1, and Chapter 19 describes these habits' effects on mucosa in relation to potentially malignant lesions. The risk varies with the habit but can be extremely high. In the southern United States, the habit of snuff dipping causes extensive hyperkeratotic plaques and, after decades of continuous use, may lead to verrucous carcinoma, discussed later, as well as squamous carcinoma. This is a very slow process, and the relative risk of developing carcinoma arises to about times 12 after 15 years and times 50 after 50 years use. Conversely, Scandinavian moist snuff, snus, appears to carry a very low risk. Table 20.1 for all smokeless tobacco habits. Carcinomas tend to arise at the site in the mouth where the tobacco is habitually held, and carcinomas are often preceded by red or white lesions or dysplasia. However, carcinogens are also swallowed, and the pharynx and esophagus are also at risk. Most smokeless tobacco users also smoke. Smokeless Tobacco Review PMID, 50. Use of e-cigarettes and other electronic nicotine delivery devices has become very widespread in just a few years. In 2018, 15% of adults in the US had used them once, but in most countries the proportion of the population who use them on a regular basis is between 3% and 6%. The attitude of health legislators to e-cigarettes varies between countries. In the UK they are promoted for smoking cessation, but they are banned, though widely available, in India. Most countries regulate use and, in the US, UK and Europe, the maximum nicotine content of vaping liquids is set at 20 mg per milliliter, and flavored fluids, likely to be favored by young adopters of the habit, are no longer available. Use increased further following the introduction of disposable devices, especially among children and adolescents, to the extent that some countries are proposing a ban. Vaping liquids may or may not contain nicotine, but all are complex mixtures that have propylene glycol or vegetable glycerin as a vehicle and flavorings and preservatives. Over 200 flavorings may be used, usually 10 to 15 in any one fluid. Many of these compounds have not been assessed for safety by inhalation or after combustion. Tobacco-flavored vape fluids contain known tobacco carcinogens, volatile organic compounds and heavy metals. The ingredients are vaporized in the e-cigarette and not burned, but this still produces breakdown products and generates novel chemicals, such as formaldehyde. Some known to be carcinogenic or to have biological effects. The final product depends on the temperature at which the vapor is generated. This complexity makes it very difficult to determine whether vaping might be a risk for oral cancer, and research lags far behind the population's adoption of the habit. Though vaping is safer than smoking, it is not harmless. Nicotine is highly addictive, causes tachycardia, hypertension, and vasospasm, risking cardiac arrhythmias and ischemia. Even without nicotine, vapor causes lung inflammation, fibrosis and remodeling of lung vasculature with secondary cardiac effects. Even young short-term users experience increased asthma severity, cough and bronchitis. An outbreak of a new condition, e-cigarette or vaping. Product use-associated lung injury (EVALI) in 2019 in the US that caused over 60 deaths was most closely linked to fluids containing vitamin E. Acetate, though other constituents may also have been contributory. Hypersensitivity to ingredients is recognized and also potentially fatal given that the reaction would be centered in the lungs. Many of these adverse effects can affect bystanders in a similar way to passive smoking. One positive effect of vaping might be that its use as a tobacco cessation aid would lead to a reduction in oral cancer. It has been estimated that the lifetime cancer risk of vaping is 0.5% that of smoking, so vaping has potential as a harm reduction strategy, as adopted in the UK. Unfortunately, though the devices have this potential, they are often adopted by non-smokers or young people in whom the adverse effects will dominate. Evidence to date suggests e-cigarettes are no more effective than other smoking cessation strategies that carry lower risks. Promoting them outside a structured cessation program may simply induce permanent nicotine dependence. No evidence yet exists to indicate that vaping might cause oral cancer, but given the potent carcinogens present in vapor, it would be surprising if there was no risk of lung and oral cancer. DNA changes have been described in the buccal mucosa of users. Anecdotal evidence has linked vaping to an oral carcinoma death in a young patient, but it may take decades to prove any association, particularly as many who vape also smoke. Other oral effects of vaping appear minimal and, to date, no distinctive oral lesion appears to be linked to vaping. Smoking, primarily through the action of nicotine, is known to predispose to gingival inflammation, periodontitis and peri-implantitis. There is insufficient evidence yet to link vaping in the same way, though the findings are suggestive of a link. Oral symptoms self-reported by e-cigarette users include oral dryness, burning, stomatitis, halitosis and bad taste. These have been linked to flavorings menthol and cinnamonaldehyde but seem less prominent than the same symptoms caused by smoking. Chemistry 33,000,004. The composition of the quid, table 20.1, varies geographically and between users, changing the risk, but overall, this habit is one of the most carcinogenic known. Addition of tobacco carries the highest risk, but areca nut without tobacco is also carcinogenic. In Thailand, where use has recently declined, the rates of oral carcinoma have fallen. Use also causes oral submucous fibrosis, and betel quid use is discussed in more detail in that section, ch. 19. Web URL 20.5 betel Alcohol. Many oral cancer patients smoke and drink heavily. The relative risks for alcohol and tobacco consumption are shown in Fig. 20.5. The increasing rates of oral cancer in the UK despite reduction in smoking have increased interest in alcohol as a cause. In Denmark, there is good epidemiological evidence to link alcohol intake with oral carcinoma, and in the Basse-Rhine area of France. Alcohol is responsible for the highest oral and pharyngeal cancer incidence in Europe. Fig. 20.5 Relative risks of developing oral cancer in consumers, males in a Western population, of tobacco and alcohol. The relative risk for a non-smoker and non-alcohol consumer is taken as 1. A smoker consuming 30 cigarettes a day and 20 alcoholic drinks a week is 7 times more likely to develop carcinoma. Drinks with the highest content of congeners, such as raw homebrewed spirits, have the closest association with carcinoma in some countries, whereas in others beer drinking is implicated. As with smoking, total consumption is probably a critical factor. Recommended maximum intakes relate primarily to liver disease, and no safe limit for oral cancer is recognized. In the UK, alcohol consumption had doubled in 50 years to an average intake of 8 litres pure ethanol each year in 2005 but has shown recent decline. The highest intakes are in older people and in low socioeconomic groups. 1 in 5 individuals older than 65 years of age drink alcohol 5 times or more each week, more frequently if male. People aged 16 to 25 years drink most, and there is no sex difference in the younger drinkers, but even in the binge drinking population there is a definite decline in intake since 2005. Despite this, alcohol consumption remains the leading cause of ILL health, disability, and death in middle age in the UK. Alcoholic drinks do not reside in the mouth for long, and there is no specific alcohol-related oral lesion. The mechanisms by which alcoholic drinks might cause carcinoma are unclear but include direct damage and increasing permeability to other carcinogens. Some mouthwashes contain more than 25% alcohol, but any link to oral cancer remains speculative, with a possible weak association only in heavy users. However, continuing alcohol use after oral carcinoma is associated with a risk of a second primary carcinoma. Alcohol and potential malignancy PMID. 16. Approximately 5% of oral carcinomas contain DNA from high-risk HPV subtypes and show P16 expression to suggest this is biologically active and potentially oncogenic. However, P16 expression is not specific and HPV DNA alone may be a contaminant or otherwise irrelevant to the carcinoma. Currently, it seems that HPV is a minor factor in oral carcinoma. A few cases may arise in minor oral tonsils and be analogous to the HPV-associated carcinomas arising in palatine tonsil and oropharynx, with a similar good prognosis. HPV does not account for the recent increase in oral carcinoma in younger individuals. Chronic candidosis causes hyperkeratotic plaques or speckled leukoplakias, ch. 15, but outside the mucocutaneous candidosis syndromes carries a very low risk, possibly none. Immunosuppression is not a significant factor for intraoral carcinoma. Incidence is not increased in HIV infection. However, lip carcinoma is more frequent in people who are immunosuppressed, ch. 21. Syphilitic leukoplakia is no longer a significant risk factor, ch. 19. Diet and malnutrition. Oral carcinoma is more frequent in those with low intake of fruit and vegetables. Vitamin A, C and carotenoids and other antioxidants are protective factors, together with zinc and selenium. Though these are epidemiologically linked, evidence that dietary intervention could prevent carcinoma is limited, though it can induce regression of some red and white potentially malignant lesions. In India, malnutrition is widespread and may contribute, together with betel quid chewing, to the high incidence of carcinoma. Diet and oral cancer PMID, 24,937,666. Folate and oral cancer PMID, 24,974,959. Diet is an herbal tea made from the yerba mate plant, a species of holly. It is drunk mostly in South and Central America, traditionally through a metal straw at a very high temperature. Use is weakly associated with carcinoma of the esophagus, pharynx and palate, probably largely as a result of the high temperature, though it also contains known carcinogens. Mate PMID, 20,036,605 and 22,915,329. Poor oral health, oral sepsis, trauma from teeth. Tooth loss and poor oral health have traditionally been regarded as contributing factors but are interrelated in complex ways with habits and socioeconomic factors. Chronic trauma has an effect in animal studies, probably by promoting constant proliferative activity, but in humans, such links remain speculative. Genetic predisposition dyskeratosis congenita, ch. 19, is rare, has oral precursor lesions and a distinctive presentation, so diagnosis is usually straightforward and established before any oral carcinoma develops. Fanconi anemia is an important but rare cause of oral carcinoma in young individuals, and oral carcinoma may be the presenting feature. Defects in several causative genes that are required for DNA repair are known, and inheritance is recessive. Patients develop aplastic anemia and leukemia and have a reduced lifespan. They are also at risk of many types of cancer, and 1 in 3 patients surviving till 50 years of age will develop one. Even more among patients treated by bone marrow transplantation. Squamous carcinomas of mouth, pharynx and esophagus are relatively frequent, and any young patient with oral carcinoma should be screened for this condition. Clues for diagnosis include pigmented skin patches, short stature and a range of other developmental anomalies, but these features are very variable and genetic screening is required for diagnosis. Case series PMID, 18,831,513. Oral cancer in young patients PMID, 33,797,696. Potentially malignant disorders. These were discussed. High-risk lesions associated with the same etiological factors as oral carcinoma, such as speckled leukoplakia, erythroplasia, submucous fibrosis and any lesion with dysplasia. Specific high-risk conditions independent of typical risk factors such as proliferative verrucous leukoplakia and dyskeratosis congenita, chronic candidosis or lichen planus that are not associated with risk habits and leukoplakia with no dysplasia and are of very low risk. The proportion of carcinomas that arise in clinically recognizable potentially malignant diseases is unknown. Patients without risk factors. A small proportion of patients appear to have no risk factors. Most are old and female, and they tend to have carcinomas of the buccal mucosa, alveolus and tongue. Many have the clinical presentation of proliferative verrucous leukoplakia, ch. 19. For the remainder, random mutation, background radiation, atmospheric pollution and passive smoking remain speculative etiological factors. There is an increased risk for individuals with a first-degree relative who had oral carcinoma, but the relative risk is very low. In young patients, those under 35 years of age, 1 in 5 have no identifiable risk factor. Oral cancer in young PMID, 24,103,389 and 33,797,696, early and late oral. It is important to recognize oral carcinomas at their earliest stages because this is the most important factor determining success of treatment. It is often assumed that small carcinomas are early in their development, but carcinomas vary widely in their aggressiveness and rate of growth. Some very small carcinomas are detected small because they are slow growing and stay small and localized for a prolonged period. Conversely, some large carcinomas may have grown in a few weeks. Thus defining early carcinoma as one at a low tumor node metastasis (TNM) stage is illogical, though it is frequently done. The smallest carcinomas appear as painless red, speckled or white patches, and only a minority are ulcerated, Figs 20.6 and 20.7. They are indistinguishable clinically from potentially malignant diseases, and approximately half of lesions thought to be erythroplasias and speckled leukoplakias clinically are already carcinomas on first biopsy. Fig. 20.6 Squamous carcinoma of the soft palate and mucosa posterior to the tuberosity appearing as a speckled leukoplakia. Fig. 20.7 Early squamous carcinoma. Despite its inconspicuous appearance, this small white patch on the lateral border of the tongue was found to be a squamous carcinoma on biopsy. After enlarging, our carcinoma may develop into a raised nodule, become ulcerated, or both. Induration results from inflammation and fibrosis and infiltration of the tissues. By the time a carcinoma has formed an indurated ulcer with the typical roll border, it will have been present for some months. Fig. 20.8. Pain is generally considered of little value in the diagnosis of carcinoma. Certainly, early carcinoma is often painless, but some patients are seen with a burning or sharp stinging pain localized to the carcinoma or an apparently normal site, so unexplained pain should not be discounted. Ulceration may be associated with soreness or stinging pain when sharply flavored food is eaten. Involvement of nerves by a carcinoma produces neuropathic pain, paresthesia or anesthesia in that nerve's distribution. Larger carcinomas may present with referred pain to the ear, through complex cranial nerve pathways. Pain increases with carcinoma size and is typically severe only in the late stages. Presenting symptoms are diverse. Maintaining a high index of suspicion is critical to early diagnosis, and any unexplained lesion that fails to respond to treatment or does not heal spontaneously should raise suspicion of carcinoma. The features of early and late carcinoma are shown in Table 20.2. Clinical features: early carcinomas PMID, 20,860,767 erythroplakia as early sign PMID, 273,632 oral cancer distribution overall. The tongue is the most frequently affected site in the mouth, and the majority of cancers are concentrated in the lower part of the mouth, particularly the lateral borders and ventral tongue. The adjacent floor of the mouth and lingual aspect of the alveolus and retromolar region, forming a U-shaped area extending back toward the oropharynx. Fig. 20.9. Fig. 20.8 Advanced squamous carcinoma. This classical ulcer with a rolled border and central necrosis is a late presentation. Note the surrounding areas of keratosis and erythema which had been present for many years before the carcinoma developed. Fig. 20.9 High-risk sites for development of oral carcinoma. The shaded U-shaped area accounts for only approximately 20% of the whole area of the interior of the mouth, but is the site of more than 70% of oral cancers. Table 20.2 Clinical features of oral squamous carcinoma: superficially invasive established carcinoma, low stage or early, high stage or late. Red patch, indurated speckled patch, ulcerated white patch, rolled ulcer, margins soft or minimally firm, nerve pain, flat or slightly depressed, paresthesia or anesthesia, superficial non-healing ulcer, loose teeth, bone loss. Pain, reduced mobility of tissue, tongue, spontaneous bleeding, palpable lymph node in neck, non-healing tooth socket. This accounts for only approximately 20% of the whole area of the interior of the oral cavity, but 70% of oral cancers arise there. This distribution may be due to pooling of carcinogens in saliva and concentration in the lower mouth before swallowing. Possibly for the same reason, the hard palate and central dorsum of tongue are very rarely affected. Pathology. The essential features of carcinoma are invasion and spread to lymph nodes and distant sites. Oral carcinoma histopathology. The key feature is invasion, Figs 20.10 and 20.11. The epithelial cells lose their organization into a surface layer of epithelium and grow into the underlying tissues. Invasion is a complex cellular process in which the cells lose their polygonal shape and rigid cytoskeleton and become motile. They induce surrounding fibroblasts and endothelial cells to aid their invasion by producing a fibrous tissue that is rich in proteoglycan ground substance and is easy to migrate through tumor stroma. Growth of new vessels is induced to supply the increased nutrient requirements of the malignant cells. In late-stage poorly differentiated carcinomas, almost all cells can show this aggressive invasive nature. Fig. 20.10. A small squamous carcinoma. At low power, the epithelium is seen to invade deeply into the connective tissue and underlying muscle. At this early stage, there is no ulceration. Fig. 20.11. Squamous carcinoma. Higher power of another carcinoma shows strands of malignant epithelium invading the connective tissue. Each carcinoma comprises many genetically different clones of cells coexisting in an ecosystem in which each clone can only survive with nutrients or signals from its neighboring cells, whether part of the carcinoma or normal cells in the tumor stroma. With time and continuous proliferation of the genetically damaged cells, there is increasing chromosomal instability and development of a more genetically diverse population of clones of cells with slightly different properties and survival abilities. Eventually, a clone with metastatic ability emerges. Only a small proportion of cells may eventually do this. Fig. 20.12. Squamous carcinoma. At high power, groups of tumor cells from the carcinoma above are infiltrating downwards between muscle fibers, seen as pink vertical bands. Fig. 20.13. Squamous carcinoma. In this moderately well-differentiated tumor, many of the neoplastic epithelial cells are forming keratin. Histologically, the individual cells show the features of malignancy: large and irregularly shaped nuclei, darkly stained nuclei, hyperchromatism, frequent and sometimes abnormal mitoses. Fig. 20.12. These are essentially the same cytological changes as are seen in dysplastic epithelium, Table 19.3, only invasion differentiates the two processes. Squamous carcinoma is graded according to its degree of differentiation, the degree to which the malignant cells resemble normal epithelium by differentiating to form prickle cells and keratin. In well-differentiated tumors, the cells have cytoplasm that stains palely with eosin or may form concentric layers of keratin, cell nests or keratin pearls. Fig. 20.13. In poorly differentiated tumors, the cells tend to be more irregular and darkly staining and show little evidence of prickle cell differentiation or keratinization. Fig. 20.14. In the most poorly differentiated carcinomas, the cells have little cytoplasm and, in the least differentiated examples, may be spindle cells not recognizable as epithelial by routine microscopy. Poorly differentiated carcinomas tend to infiltrate more widely at an early stage, are more likely to metastases and carry a poorer prognosis. The majority of oral carcinomas are moderately differentiated. Fig. 20.14. Squamous carcinoma. In this poorly differentiated carcinoma, there is no keratin formation, no organization into basal and prickle cells, and the malignant cells show great pleomorphism with variably sized nuclei, many of which are hyperchromatic. Carcinoma, malignant epithelium is invading around nerve sheaths. Although this is infrequent, occasionally carcinoma may spread some distance from the main tumor mass along nerve trunks. Local spread: the invading cells grow into the tissues by direct extension. Irregular branching processes penetrate the tissue, the tips of which are often cut off in a histological section to give the appearance of separate islands of tumor. See Fig. 20.11. In the more infiltrative, poorly differentiated carcinomas, single cells and small clusters of cells detach along the invasive front of the lesion, forming a discohesive invasive front. This carries a higher risk of metastasis than a cohesive invasive front of large islands of epithelium. Aggressive carcinomas may show perineural infiltration, selective spread along nerves, or vascular invasion, Figs 20.15 and 20.16. Both of which are adverse prognostic features. Carcinomas that spread along nerves are less likely to be easily excised and more likely to recur because of their unpredictable outline. Those with vascular invasion are more likely to metastases. Fig. 20.16. Squamous carcinoma. Less frequent than perineural invasion is vascular invasion. Here a cluster of poorly differentiated malignant epithelial cells have eroded the wall of the vessel and entered the circulation. Tumor cells invade all tissues. Fig. 20.11. Muscle, fat, nerves and eventually bone are infiltrated and destroyed. Carcinoma induces resorption of the bone by activating normal osteoclasts across a broad front, source rising, the cortex until it can invade the medullary cavity to spread more widely and destroy the bone from within. Invading cancer cells excite a variable inflammatory and immune reaction and can become surrounded by lymphocytes and plasma cells. Tumor-infiltrating lymphocytes to kill some carcinoma cells, but unfortunately, the immune response provides no significant protection. Perineural infiltration PMID, 25,457,832 pattern of invasion PMID, 23,250,819 and 8,039,106. Clones of cells in the tumor eventually acquire the range of abilities required to migrate, penetrate lymphatics, survive as single cells during transit, lodge in a lymph node and proliferate to form a metastasis. For some time before metastasis develops, cancer cells can be detected in the circulation but fail to seed metastases. These cells presumably lack some of the necessary abilities and are killed or die in the circulation. The specific sites of metastasis depend on the drainage of the tumor site, but, because most carcinomas arise posteriorly in the lower mouth, the submandibular and jugulogastric nodes are those most frequently involved. Lymphatic drainage from the tongue is shown in Fig. 20.17. Floor of mouth carcinomas and others involving or crossing the midline may spread bilaterally. Metastases develop progressively down the jugular lymphatic chain. Fig. 20.18, reaching level 4 supraclavicular lymph nodes at a late stage. Although these patterns of spread are relatively predictable overall, there is great difficulty in identifying and predicting metastatic spread to the neck when planning treatment for an individual case. Spread of cancer may be by an abnormal route, and all the lymph nodes of both sides of the neck must be examined and imaged. Metastatic carcinoma is initially limited to the affected node but, in time, grows through the capsule into the tissues of the neck. This is a marker of an aggressive carcinoma. Excision is then difficult, and the chances of survival are diminished. Extranodal spread is evident clinically as fixation of the node. Fig. 20.17. Typical routes of lymphatic spread from lip and intraoral squamous carcinomas, purple, to nodes, green. Fig. 20.18. Neck levels for assessing metastasis for TNM staging. The neck is conventionally divided into level 1, the submandibular and submental region nodes, 3 levels 2, 3 and 4 down the jugular chain, 5 in the posterior triangle and 6 in the anterior neck. Metastasis patterns follow lymphatic drainage, and lower neck levels carry a poorer prognosis. In contrast, thyroid carcinomas metastases to levels 6 first, then 3 and 4, while metastases in level 5 are usually from the skin or pharynx. Metastatic carcinoma forms a hard mass when small, but in larger masses the central area can become necrotic. The center may then break down, so that the metastasis becomes cystic and fluctuant clinically. Bloodstream metastasis is an uncommon, late feature of the disease and often after several episodes of treatment. Metastases then develop most frequently in lung, followed by liver and bone, heralding a terminal phase. Key features are summarized in box 20.3. BO by 20.3 ORALCANC. CL. Patches or shallow ulcers and are painless or only slightly sore. Later carcinomas appear as ulcers with prominent rolled edges and induration and become painful. More than 70% of oral cancers form on the lateral borders of the tongue and adjacent alveolar ridge and floor of mouth. Over 95% are well or moderately well differentiated squamous cell carcinomas. Spread is by direct invasion of surrounding tissues and by lymphatic metastasis. The submandibular and jugulogastric nodes are those most frequently involved. The prognosis deteriorates sharply with lymph node metastasis. Tumor thickness and metastasis PMID. 16,240,329 metastasis. Poor prognosis PMID. 20,406,474. Site variation. Tongue. The lateral border of the anterior 2/3 of the tongue and the adjacent ventral tongue are common sites. Conversely, a carcinoma arising centrally on the dorsum is extremely rare. Carcinomas of the tongue must invade only a millimeter or so before they enter muscle, a vascular tissue that seems to promote carcinoma growth. Carcinoma in the tongue is renowned for its unpredictable spread, in part because growth is directed along muscle bundles, which in the tongue radiate all directions. Carcinomas sometimes show selective sarcolemmal spread along muscle fibers and grow out long thin extensions of tumor, often reaching the midline at a relatively early stage. The tongue becomes progressively stiffer and more painful. Eating, swallowing and talking become a challenge. Carcinoma of the tongue is also known for its unpredictable metastasis. In addition to drainage to lymph nodes around the submandibular gland in level 2, carcinoma of the lateral border will metastases directly the jugulo-omohyoid or other nodes in level 3. 1 in 5 carcinomas generate such fast-track metastases directly to level 3 without involving level 2 first. Once the midline is reached, metastases may develop bilaterally. Tongue carcinoma develops metastases at an early stage. Floor of mouth. Unlike tongue carcinomas, floor of mouth carcinomas tend to spread laterally, producing broad, relatively superficial tumors. If they extend to the alveolar mucosa, they may erode bone, and if they extend up onto the ventral tongue, they may then extend into underlying muscle. Most arise anteriorly. Treatment is difficult, and this site carries a poor prognosis. More carcinomas here are poorly differentiated, and there are few barriers to spread to deep vital structures. Metastases occur early, in almost half of patients on presentation. Alveolar ridge and gingiva. This site accounts for approximately 10% of all oral carcinomas. Patients tend to be older people. The carcinomas tend to be well differentiated and more slowly growing than tongue carcinomas but erode bone at an earlier stage, making treatment more complex. However, only a minority invade the underlying bone in a dispersed pattern, and the cortical bone is usually resorbed without penetration far into the medullary cavity. These carcinomas have a lower risk of lymph node metastasis. Metastasis is usually to the relatively easily treated levels 1 and 2. Unfortunately, despite these good features, gingival carcinoma often shows delayed diagnosis, being mistaken for inflammatory periodontal disease or denture trauma. It is important not to extract teeth adjacent to such a carcinoma because that allows the carcinoma to spread deep into the medullary cavity easily. Buccal mucosa. At this site, Carcinomas erode the soft tissue and eventually penetrate through to the skin. Most arise posteriorly, and some are associated with beetle quid chewing. Retromolar region. This is a common sight but difficult to treat because carcinoma may spread into underlying bone, medial to the ramus to the pharynx, laterally into the cheek and up to the tuberosity region and infratemporal fossa, making surgery and reconstruction difficult. Half of cases present with metastases. Management. Early diagnosis is critical if patients are to be cured because survival is highly dependent on tumor size. Even after diagnosis, the speed of treatment is critical to outcome and patients need to progress rapidly along the treatment pathway. However, this urgency must be balanced with assessment of patients' expectations and understanding of treatment. Surgery and radiotherapy produce significant morbidity, and the quality of life of survivors of large operations and radiotherapy can be poor. Patients will spend a week or two undergoing intensive investigations and planning and may feel rushed into making decisions about their treatment and life after treatment. Good communication and rapport with patients can be as important as good surgery or oncology. Treatment should be performed in a specialist center because these have been shown to have superior outcomes. Resources are concentrated to make the widest range of treatment and support available. Patients should follow a defined pathway, as shown in Table 20.